Good day, everyone. I assume we are having a few people from different time zones. It is my pleasure to start this seminar on left bundle branch area pacing with our main speaker, Dr. Chandh Raja, from Chennai, India, and myself is Eugene Crystal, and I'm introducing my esteemed colleague, Dr. Deepak Padmanabhan, who is also at the moment located in India, I assume. This is a part of WSA, World Society of Arrhythmias seminars on bradycardia, and this one obviously is a more advanced part of bradycardia treatments. So without further ado, please feel free to put immediate comments in chat, and I will ask Dr. Deep Raja to start, please, Deep.
Dr. Deep, the session is yours.
Thank you, Dr. Deepak. Let me ensure that my screen is visible. Yeah, a warm welcome to all of you. Just let me know if...
Deep, you're visible. And so
Yep.
are you.
My screen as well.
Yes.
And you have very few second delay. So that's what we feel, yeah.
Yep. So the topic for the day is left bundle branch area pacing. Let me start with this case. A 58-year-old male, a diabetic hypertension, presented to our clinic with symptoms of syncope, obvious bradycardia on the ECG, very slow sinus rate, and a junctional escape rhythm seen there. The patient had a dual chamber pacemaker, as we conventionally and routinely do. This was way back in 2012. As you see on the ECG, an A pace and a V pace rhythm there. Two spacing spikes on V1. You see the QRS on the ECG. The QRS is quite broad here, 150 milliseconds, but quite acceptable. That's how it looks like when you place a lead on the right ventricular apex, and that's the routine way we do it. But the problem here is the patient came with heart failure symptoms after 6 years of the pacing. The problem with every apical pacing is, as I've highlighted here on the 3D electroanatypical maps, what happens in intrinsic sinus rhythm is synchronous activation of both the right side and the left side ventricle. But what happens with an RV pacing is the right ventricle gets activated first and then the left ventricle. You are introducing, and we are introducing, a left bundle branch block. We are introducing a dysynchronous activation of the ventricles. Over time, most of the patients do well, but then not all. 10 to 15% of these patients over time, the duration could be as early as 1 year, or it could be 5 years, as in this particular case that I had shown, end up in a pacing-induced cardiomyopathy, which is defined by a reduction in the left ventricular ejection fraction by more than 10%, if the baseline ejection fraction was normal, and if the patient's RV pacing burden was more than 20%. And obviously, we rule out other definitive causes, especially coronary artery disease, or any new onset left ventricular dysfunction, or any inflammatory cardiomyopathies. After which we blame it on pacing-induced cardiomyopathy as the particular reason for a patient to have this particular decline in the LV and ventricular functions over time. So Dr. Eugene Crystal and Dr. Deepak, what do you think about this pacing-induced cardiomyopathy? How frequently have you seen this in practice? A quick comment from you, and then I move on.
Dr. Crystal, your thoughts on this really challenging incidence?
Yeah, thanks. So I think it's kind of very important to understand very few basic concepts, that we do have bradycardia related treatment as right ventricular apical pacing for decades, right? And we always recognized that for the certain percentage of our patients, it's not working well, and it seems to be incremental over the time. So that's one observation. The second was always that if you would start upfront in someone who is already compromised in terms of a baseline ejection fraction, the effect seems to be more devastating. And more importantly, there was always this small amount of patients, between 1 to 3%, who were falling apart right after AV junction ablation with RV pacing, and we didn't have a good modality to control it. So I think that was very important discovery, kind of to develop a concept of this cardiomyopathy and move on by idea of pacing the conduction system. That's my only comment.
Deepa, I agree with
Thank you,
Dr.
Dr. Crystal.
Go ahead.
Yeah. So, Ellen Bogan and his group and Dr. Pugal Vijayaraman and his group, they were working a lot on this pacing-induced cardiomyopathy back in the 2000s and 2000, the second decade of the century. And then they came up with a very important landmark investigation paper telling that conduction system pacing with his bundle pacing, first of all, is feasible, it is safe, and more importantly, is superior to right ventricular pacing in routine clinical practice. When you mean superior, they meant reduction in heart failure hospitalization, reduction in pacing-induced cardiomyopathy. Of course, the article or the study was not powered enough to show a mortality benefit, but then it did show quite a significant reduction in heart failure hospitalizations because of pacing cardiomyopathy. This was an eye-opener way back in 2015 that gave us an introduction of this is how a conduction system pacing is going to flower or bloom in the coming years. So this is an anatomical specimen, the AV node of the His bundle, as you see it from the right side of the heart. What we do here is place a lead onto the right side of the septum, which is the atrioventricular junction, and that lead captures the His bundle. This was how conduction system pacing started. Now it's a decade of conduction system pacing. This was how it started 10 years back. We used to place a lead in the atrioventricular junction, screw it into the atrioventricular junction, and make sure that it captures the His bundle. That would result in an excellent QRS. But then there were problems with His bundle pacing. The acute success rates were not 100%, 20% failure rates. More importantly, lead revision rates were around 5 to 10%. We hate, as implants, we hate our patients to come on table again for lead revisions. We do not want to see that. And we do not want to increase the infections of the pocket just because we need to revise the lead. Damage the His bundle, and the learning curve was a bit steep. Then in 2017, Huang came with a landmark paper from China that he came up with a novel pacing strategy that it is not necessary to capture the His bundle. You can capture the left bundle branch block just beneath the His bundle. If you place the lead a bit deeper into the septum, that was the second introduction on conduction system pacing given by Huang, that you can go a bit deeper into the septum where you will be able to capture the left bundle branch. In fact, his patients were patients where he wanted to correct left bundle branch block with left bundle branch pacing in heart failure patients. That's how the second phase of conduction system pacing started. At that point of time, we had a wonderful lot of options in our plate of where we could place the lead. It could be in the location number 1, the His bundle, location number 2, which is the left bundle, which is the proximal left bundle, location number 3, which is the distal left bundle, which is basically the physicals of the left bundle. Location number 4 is the routine location that we place the RV endocardium. And L5 and 6 are on the left ventricle side that we use for pacing for cardiac resynchronization therapies. So basically, it is number 2 and number 3, this proximal and the distal left bundle, what we together mention as left bundle branch area pacing. So there we enter a new era in pacemaker therapy, which is the left bundle branch pacing. And nowadays, if we say conduction system pacing, unless otherwise, we mean left bundle branch pacing. Getting into the anatomy of the left bundle branch, the way it looks on the fluoroscopy, left bundle never manifests itself on the right side of the septum. It is on the left side of the septum. But how do you reach on the left side of the septum? By taking the lead deep into the septum, by screwing the lead well past the right side into the left side, and hence we reach the left side of the septum. So this is the lead as I've shown here, the left bundle branch lead, which is in pink color. The lead you see here, the routine lead is on the RV endocardium, but if you see the lead on the left bundle, you get the lead past the RV interventricular septum, deep into the septum, much further about to abut the left ventricular endocardium. That's where you would see the left vesicles. And if you happen to place the lead deep into the septum, if you happen to capture the left bundle, that's how cute the QRS would look like, a very narrow right bundle branch block morphology. Right bundle branch block morphology because you're pacing the left side of the vesicle or the left side of the bundle. And hence the QRS morphology, because you're directly capturing the conduction system, the QRS tends to be very narrow. Little more depths of how this left bundle branch lead looks on a CT scan. We did were interested in the early part of this decade to understand how deep you need to get into the septum to really capture the left bundle. What we thought was if you have to lead much deep, like 70% into the, at least 70% across the septum, that's where you will be able to capture the left bundle successfully. As I mentioned in the slide previously, there's proximal left bundle that you can capture. That is the distal left bundle. You can directly capture the distal left bundle, which is basically the left vesicles. The vesicles could capture the left posterior vesicle. So your 2, 3, and AVF will be negative if you capture the posterior vesicle. The QRS will be an RBB morphology and is going to be very narrow, less than 120 milliseconds. It is possible to capture the anterior vesicle as well, where 2, 3 AVF tends to be positive. Again, we tend to have our RBB morphology, right bundle branch block morphology, with a very narrow QRS less than 120 milliseconds. So that moves on. That's an introduction how the anatomy of the left bundle is. And then I move on to case selection. Which patients do you select before you have them plan for a left bundle branch pacing? This is a complex slide taken from the guidelines, the latest guidelines from the Heart Rhythm Asia Pacific, the Latin America Heart Rhythm Society guidelines. Let me summarize the guidelines to you in 2 boxes. 1, bradycardia indication. If the patient has a bradycardia indication and need for ventricular pacing more than 40%, and with a normal left ventricular ejection fraction, it is worthwhile to pursue left bundle branch pacing. If the patient has left ventricular dysfunction, less than 50% of ejection fraction, and the need for ventricular pacing is still high, like more than 20%, again, the patient would benefit, class 2A indication, would benefit from left bundle branch area pacing. Indication number 2, heart failure patients, where we are looking to correct the left bundle branch block. Obviously, patient has a complete left bundle branch block, wide QRS, low left ventricular ejection fraction, where we have taken a call. The correction of the left bundle branch block would cause an improvement in the left ventricular ejection fraction. We try with the routine coronary sinus leads, but due to suboptimal targets in the sinus lead or suboptimal response on table, we choose to do a left bundle branch area pacing on these patients. This is indication number 2. Before I go to the case examples and implant techniques, I would stop here and I would invite comments from Dr. Eugene Crystal and Dr. Deepak and the audience, please.
Thanks a lot, Deep. That was excellent introduction. I'll ask my colleague Deepak to start commenting.
Deep, what do you think is the difference in the anatomy vis-a-vis the his bundle location, the proximal left bundle, and the distal left bundle
So,
area?
yeah. So his bundle is very proximal part of the conduction system. It goes, and this is how the bundle branches into a left bundle, anterior, posterior physical, septal physical, and the anterior physical, and the right bundle branch. So his bundle is basically located at the junction of the atrium and the ventricles. If you can look at this this is the area overview that I've shown here. This is the plane of the tricuspid annulus, and that's exactly where the his bundle is located. So his bundle is proximal part of the conduction system, whereas the left bundle is distal to the his bundle, and then his bundle divides into the left bundle and the right bundle, as all we know. We all know, understand that. And the left bundle is like a screen, a broad vesicle that's located on the left side of the septum. Difference number one, his bundle is a very focal structure, a focal target, a small target, whereas left bundle is a wide target. It's easier to get to the left vesicles because the left bundle branch is not a bundle. It's in fact like a screen there on the left side of the septum. Anything to add on, Dr. Crystal?
Not really on that particular side, but as you transition to your cases, my question to you, how this sudden concept of, so to say, pacing mapping, right, are changing the flow and the timing, of your implantation, which is very practical question, increasingly often.
Yeah.
Yeah. So his bundle is a very small target, whereas left bundle branch is a broader target. It must be easier to get to the left bundle than getting to the his bundle. As I mentioned, his bundle is the proximal part, and yeah, there are problems with his bundle branch pacing that we have had, and hence we have moved on to left bundle branch pacing, the other part of the conduction system. And these are the primary two indications, and I will show you in the case examples, 4 case examples to discuss in the case examples to follow. We'll be discussing all these indications and the implant techniques.
One thing
The
I'd like to,
options, yeah,
one
please,
thing
please
before
go
we
on.
just move ahead is I would like our listeners to appreciate the fact that this is still a pacing requirement. And when we attempt to do his area or his bundle pacing, you are essentially looking for a focal target surrounded by no myocardium. It's still the membranous septum out there. Whereas with the left bundle, the necessity to have another pacing backup wire in case there is any challenge with the capture of the conduction system, that has probably been um, phased out, and that I think is the biggest advantage of having into the left bundle, where in a dependent patient you're not really worried that you're going to lose capture because muscle is all around the left bundle as well as the left fascicles, whereas in the his area it's just membranous septum, so just a focal point, you lose capture because of fibrosis, because of movement of the lead, micro dislodgements. You're basically rendering the patient non-dependent, I mean without any pacing backup. So to me, that aspect of anatomy was what is very fascinating and probably has led to an advantageous situation for the left bundle pacing area enthusiasts as compared to those being on the his bundle. Go for it. Just wanted to make that point, but thank you.
Thank you for the comments. So before me getting into the case examples, there are 2 leads that we commonly use to get it past the interventricular septum to the left bundle branch area or to the left ventricular endocardium. One is the lumenless leads, the Medtronic, famously called the Medtronic 3830. That's how we started this bundle and left bundle branch placing. So this lead is quite being the workhorse even nowadays to get to the left bundle branch. Remember, this lead does not have a lumen. This has a fixed screw helix at the tip, and it's a smaller lead, 4.1 French in diameter. Okay. It's a very slender lead, nevertheless good enough to take the lead past the interventricular septum. And the lead comes with, the Medtronic comes with its workhorse sheets The sheet that we commonly use is the C315. The C315, this combo of C315 select secure and the 3830 lead is still the workhorse for many to get into the left bundle branch. And then was the advent of the stylet-driven leads, thanks to the other companies who pulled up their socks, Abbott, Biotronic, and Boston, and they started manufacturing sheets. They did not change much in their leads, but they started manufacturing sheets. They started encouraging the physicians. Of course, it started with a few studies where they showed it's possible to take the routine leads of the Abbott, Biotronic, and Boston using custom-made sheets and using proprietary sheets manufactured by each of these companies to get passed into the interventricular septum. So this is an example of a lead, of a stylet-driven lead, which has a lumen inside, which means it can harbor a stylet. And then this screw is retractable, and like the fixed screw of the 3830 lead, the stylet-driven lead has a screw which we routinely use for the endocardial pacing, which is very much retractable. And then now we have an array of sheets which can aid us in getting past the interventricular septum. It could be Medtronic C315, which is used to take the lumenless lead. They also have a sheet which is capable of flexion. Then the Biotronic has come up with sheets called the Selectra 3D sheets. Boston Scientific has its own set of sheets. And Abbott has two sets of sheets. One is the Agilis His Pro, which has a flexible handle, and one more commonly used, the medium and the large curves, or fixed curve sheets. So much of the companies have come with fixed curve sheets. Medtronic and Abbott have their flexion on the curves that is possible, which is the Agilis His Pro. And of course, the leads for the Abbott, Boston, and the Biotronic, they are the routine, Ingevity, Tendril for the Abbott, and the Soleus for the Biotronic leads, which, with the aid of the newly made sheets, they were able to take past the left bundle branch or the interventricular septum. In this first case, a 72-year-old male, post-aortic valve replacement in 2002. The patient had a symptomatic atrioventricular block, had a VDD pacemaker. The patient had a dual chamber upgrade, a pulmonary replacement in 2014. Unfortunately, the RV lead failed to capture. More importantly, the left ventricle started going down, landing the patient in a high-grade AV block with a moderate LV dysfunction. As you can see here, the patient's intrinsic ECG showing a left bundle branch block and the RBB morphology, basically an alternating right bundle and a left bundle branch block. And this is because the RV lead failed. That the patient's own intrinsic started coming up, we started noting this alternating left bundle branch block. In this background, I would like to go through the steps of left bundle branch pacing. The first thing, even before taking the patient on table, we would like to assess the patient's echocardiography and like to see how thick the septum is, the interventricular septum. The interventricular septum could be the normal thickness, less than 15 mm, or it could be much more, like a 20 millimeter basal interventricular septum. We understand that a lot of patients with systemic hypertension, the basal septum tends to get hypertrophied. The basal septum is where we need to get into the left bundle branch. And if that part of the septum is hypertrophied, we need to think about a strategy on how to get past the interventricular septum. Whether to choose a lumenless lead or a stylet-driven lead if the septum is thickened. I will leave this part of the discussion to Dr. Eugene to discuss more. If the septum is thick, what is the choice of the lead that he would prefer to get past interventricular septum? So looking at the ventricular septal thickness by echo scan is going to be the first important thing. And if we are dealing with a patient of ischemic cardiomyopathy and we are looking at a heart failure indication for the left bundle branch block, we would be really interested to know if that is scar in the interventricular septum, for which a cardiac MRI would be really helpful. A CMR would be really helpful for us to understand if that is scar in the interventricular septum. In inflammatory cardiomyopathies, again, we will have a lot of scar on the basal anterior septum or the basal posterior septum. So it helps us to understand where the scar location, if we are particularly dealing with a heart failure indication, and if we are looking at a left bundle branch correction for a CRT, and then we need to understand also the scar. So this is the basic. We start looking at the echocardiography and the scar, understand the thickness and the location of the scar and the thickness of the scar. Of course, if the patient has an intrinsic rhythm like a left bundle branch block, there are high chances that we will injure the right bundle branch block in trying to negotiate. We might end up in a complete heart block on table. We do not want catastrophe on table. Hence, we would have a temporary pacemaker implanted, a TPI implanted before we take the patient up. Again, it would leave the charge to the operator in non-left bundle branch block patients it's preferable to have a temporary pacemaker, but not at all times. You could go directly with the left bundle branch pacing lead. The most important view once we are there would be the right anterior oblique view, as I would like to show in these slides. And then the way we screw into the interventricular septum is going to be the left anterior oblique view. So these are the two views, a bit different from our routine conventional pacing, where you use AP view or RA view, quickly go into, place it in the right ventricular apex and come out. But unlike for a left bundle branch pacing, we make sure that we start with right anterior oblique view, choose the site of penetration or where we would like to go past the septum, and then in the left anterior oblique view, which is step number 2, where we get it past the left ventricular septum. Into the details during the course of slides, I think it would be self-explanatory, like how we look at sheath angiography, the fulcrum sign, how we monitor the impedance, and the way we look at the QR morphology, to give us the feedback whether we go on to the left ventricular system. So, very important, such important thing, taking the long sheet in the right ventricle. Whatever kind of sheet that we use, very important to understand that we would not prefer take the sheet directly past the tricuspid valve into the ventricle without a wire support or without taking the lead support. This is because these tend to kink, and when they kink, it becomes very difficult to get lead past kink back into. Hence, we always maneuver the sheet either with a wire inside, as shown here. Wire is passed into the pulmonary artery, and then we take the sheath past the.
We can see you, Dr. Deep.
Oh, yeah, that was an interruption there. Let's start back. Are my slides visible again?
Just give it a second.
Are my slides visible again?
No. Just give it a
Okay.
second.
Yeah.
I'll let you know when it's on. There you go. You're on.
Sure.
Yeah. So I was telling that how we sheath the tricuspid valve only with wire support or with the pacing lead inside. We never take the sheath directly into the right ventricle without any support. We would tend to kink the sheath, which is not good for the latter part of the case. The second part is choosing the site of penetration. So we prefer to have the right anterior oblique view, preferably 30 degrees. There are different ways where we would visualize the plane of the tricuspid annulus. With building or experience, one would directly visualize the tricuspid anterior annulus with a fat pad. The superior part of the tricuspid annulus is where the His bundle is located. In the early part of implants, this was how Huang had started the implants. He would place a His bundle lead, and then he would take a left bundle branch lead deep into the ventricle, 1 to 1.5 centimeter distal from the His bundle towards the right ventricular apex. There are other ways you can do it as well. You take an electrophysiology catheter, a quadripolar catheter, place it across the His bundle, and then you can place or choose a site 1 to 1.5 centimeters distal to the His bundle catheter. That would be the location where you would preferably start trying to get into the left bundle. Site number 2, if you fail in that particular location, would be a bit much distal. Site number 3 would be the left posterior physical, the region of the left posterior physical, inferior, and little more towards the apex. And site number 4, a little more anterior. That's where you would likely end up capturing the left anterior physical. So once you have chosen your site of implant or site of penetration, we tend to give really fast rotations. There are beautiful animal studies that have shown that the lead tends to get entangled in the right side of the septum. As you can see here, I would like you to appreciate the fastness in which these screws or the turns are being given, especially with the 3830 Medtronic lead, to aid us get past the interventricular septum. The fastness is important, I would like to emphasize here, because of a phenomenon called endocardial entanglement. And endocardial entanglement is a real problem if you try to go slow with the 3830 leads. Endocardium, the right ventricular endocardium is like a screen there, which you will be able to peel off from the myocardium, mid-myocardium. And if the lead gets caught in the endocardium, then it's really just moves round there. You will not really get past this interventricular septum. And hence, the fastness of the movements there, trying to pierce the lead fast into the interventricular system, helps us get past the endocardium quickly into the mid-myocardium. And from there on, the rotations could be slower. At that point, it's important to have the connections. At this stage, I would like to introduce the audience to a different nomenclature that we never used to do it with the routine RV endocardial leads. This is the unipolar mode of pacing, where we want to see what the tip captures. We do not want to see what the anode captures. We just want to see what the tip captures, how far the tip is into the interventricular septum. What is this capturing? That's exactly what we would like to know. And hence, we connect the black clip to the tip, whereas the red clip is connected to the tissue or to the metal clips so that it doesn't receive any signal. What happens is you end up pacing only the tip of the lead, and that's exactly what we would like to see while we take the lead past into the interventricular septum. We are not interested at that point to see what goes on in the anode. We just want to see what happens in the tip. So what are the parameters that we look for while we screw the lead past into the interventricular septum? The unipolar QRS morphology and the impedance change in the unipolar. The program is out there. There's continuous monitoring. There's a 12-lead classically displayed on the screen and should be always described. I would spend a bit of a time here to explain. When we start on the RV endocardium, we choose an area where you start seeing this notch, a typical notch on the left bundle branch block morphology, a notch here. And with some sort of a discordance in the lead 2 and lead 3. And if you're able to see a discordance in AVR-AVL, that helps as well. If you're seeing a left bundle branch block morphology with passive pacing, and if you have a notch in the left bundle branch block, this is a good site to start with. You start seeing the impedance, which is 400 ohms. This is before screwing. And as you start screwing the lead into the interventricular septum, you keep an eye on the impedance. The impedance increases 660 ohms. That's because we are past the endocardium into the myocardium. Slowly, you see the notch in the left bundle branch, the descending limb slowly moving towards the latter part of the QRS. A little more of penetration. The impedance increases further, 750 ohms. That the notch disappears, but the J point starts elevating. Little more deep inside, a little more prominent J point, a large Q, and little more. At this point of time, the rotations are to be slow. 1 or 2 rotations further, you start seeing a dip in the impedance. That's when you stop rotating. and you start seeing a right bundle branch block morphology. And that's it. You have then now reached into the left side of the interventricular septum. And if you see a right bundle branch block morphology with such a narrow QRS, you have captured the left bundle or left posterior physical of the left anterior physical. But you have successfully captured the conduction system. So again, the points to reiterate here. Before you start pacing from the right side, you look for this left bundle branch block morphology with a prominent notch, what we call the W pattern. And if you have discordance in lead 2, 3, and AVR AVL, that's a good start to start with. As I mentioned, 1 to 1.5 centimeters distal to the his bundle. Then slowly we start taking the lead deep into the septum. The notch starts moving deep inside. You start seeing an elevation in the J point. And when you start, the impedance starts rising and then starts dipping. That's when you know that you have reached the left side of the septum. So there is another important parameter that you can look for while screwing, what we call the template beats. They are basically the premature ventricular contractions or PVC complexes that arise when you are reaching the left side or deep into the septum. This could give us a clue as well if you have reached the left side of the septum. Like as shown in this case, if you see a RBB morphology, narrow QRS ectopic beat, then you know that you have already reached the left side of the septum, or you are in the region of the left bundle branch. Again, this is another example telling as you get past the interventricular septum, the way the morphology changes from an LBP morphology, and slowly you start seeing a QR pattern. There are a lot of criteria put forward. It's available in literature. You can all go into the details, but then I would like to simplify the criteria here, because much of the places in the regions where you would like to implant the left bundle branch area, most of the times we rely on the QRS morphology. So what we look on in V1 is basically QR morphology or a right bundle branch block morphology. As shown here, a small Q and a capital R, or an RSR prime. If you see an RSR prime like this, and the QRS duration is there 120 milliseconds, and the V5 to V6 LVAT. LVAT stands for left ventricular activation time. And what is left ventricular activation time? The time taken for the intrinsicoid deflection, which means the time taken from the pacing stimulus to the peak of the R wave. In this particular case example, it is 90 milliseconds. So the time taken from the stimulus artifact to the peak of the R wave in V6 or V5, that is left ventricular activation time. That's understandable because V5 and V6 are leads that are located laterally, and that is representative of how quickly the impulse travels down the left bundle and captures the lateralmost part of the left ventricle. So if the left ventricular activation time is less than 80 milliseconds, QRS is less than 120 milliseconds, and the morphology of the QRS is QR in V1 or an RSR prime in V1, then you can be relatively sure that you are capturing the left bundle branch or one part of the left bundle branch, which could be the left posterior fascicle or the left anterior fascicle. Coming back to the case example that I started off, where we needed to do the RV lead failed and we needed to put a new left bundle branch area pacing. We ended up putting a left bundle branch lead there in this patient. That's how it looks on the echo scan after you push the left bundle branch lead. You see the lead very much a echogenic structure past the interventricular septum, abutting on to the left ventricular endocardium. And this particular patient had really improved ejection fraction down the lane. So we did an ECG guided testing of left bundle branch capture. This is where I would like to introduce another concept, unipolar mode and a bipolar mode. In the bipolar mode, now that we know that the anode and the cathode both are inside the interventricular septum, it's high likelihood that both the anode and cathode will start capturing the myocardium. So there will be a change in the morphology when you switch from a unipolar mode to bipolar mode. This is basically unipolar mode or in low output of bipolar mode, where you will see The relatively narrow QRS, RSR prime pattern, as shown in this case example, is basically left septal physical selective capture. But either at high outputs or in a bipolar mode, when both the cathode and the anode start capturing, the RBB morphology would disappear and would change into an LBB morphology. That is basically because both the anode and the cathode are capturing the myocardium. When the cathode is much deeper into the interventricular septum, the anode is on the right side of the septum, and hence the left bundle branch block morphology. Nevertheless, the left bundle branch block morphology is still narrow. The resultant QRS is still less than 120 milliseconds. But what we need to understand here is this particular QRS, which is left bundle branch block morphology, is the result of capture of both the anode and the cathode, because at this stage, the cathode is well past deep into the interventricular septum, and the anode is still across the interventricular septum, and hence the resultant capture is a fusion of both the anode and the cathode, and hence the QRS is a mix of both the anode and cathodal capture, hence it is a LBB morphology. This appreciation of change in morphology from right bundle branch block to a left bundle branch block when you switch the modes or in high outputs is again one of the criteria for left bundle branch capture. So I've introduced that particular concept of a bipolar mode and how the anodal capture looks like. So 4 possible outcomes with the left bundle branch pacing. If you're on the right side of the septum, you would still have a capital Q and a KS, which is basically a LBB morphology. If you're deep into the septum, you would have a capital Q and a small r, which is just means deep septal pacing. The QRS would still be more than 120 milliseconds, which is what we call as a RV or deep septal pacing. This is LV septal pacing. There is no real left bundle branch capture. And what we call as a true left bundle branch capture is when the QRS starts narrowing less than 120 milliseconds, and the LVAT is less than 80 milliseconds. LVAT is basically the left ventricular activation time that I had shown. And when you're deep inside, you would either get a QR morphology, a small q and a capital R, or you would get an RS R prime pattern. And the reason for the narrow QRS that you see, the cute little QRS, is because on the left side of the septum, you capture the left bundle, it quickly transmits via the Purkinje fibers into the myocardium. It also climbs up the hills and comes back into the right ventricle, or it captures directly the right ventricle because the anode is passed across the interventricular septum. Hence, the QRS is very narrow here. So at this point, before going into the left case 2, Dr. Eugene, Crystal, and Dr. Deepak, I would want you to discuss a bit more about the techniques and anything you would like to add upon this.
So thanks a lot, Deep. That was absolutely a great way of taking us through the stages of confirmation of exact area of pacing. I would give it to my colleague Deepak to comment on that so far.
Deep, thank you for that. That was very informative, succinct, and probably I hope people who see this are able to get the gist of what it is that you're saying. Now, tell me more. How are you able to figure out that you need to stop? I mean, we all understand the morphology. So, how is it that you, with respect to a stylet driven lead and a non stylet driven lead, are able to figure out when to stop? Because you could overshoot, you could go into the left ventricle, and sometimes you may want to say, hey, I've got a reasonably narrow QRS. My LVAT is good. Do I really need to want to go that extra level so that I get a better looking QRS, probably left bundle capture or left fascicle capture, and then you end up perforating or entering the left ventricle? So, how do you kind of manage that conundrum?
Thank you for that question, Deepak. It's not uncommon to perforate the interventricular septum even after having done so much of cases. You would as well allude to what I say, that we do tend to get past the interventricular septum a lot of times, and the lead freely moves within the left ventricular cavity, much to our dismay. And then I would like to tell the audience that do not worry, nothing happens, nothing catastrophic or big happens. You would still be able to come out of the septum back into the interventricular septum, or there is no big complication that happens on table. But then it does tend to happen. But then the points that we look for very carefully to see that we don't get past the interventricular septum into the left ventricular cavity are number one, drop in impedance, as shown here. When you start getting a drop in impedance, which means already a part of the screw is past the left ventricular endocardium, that's when point number one, I would prefer to stop. If I don't get a right bundle branch block morphology by then, I need to reposition the lead and take it in a different location. As I had shown, I would choose site 2, site 3, site 4. But then if I've got a right bundle branch block morphology already, I've shown in this case as an example, and that's a drop in impedance, would stop there. That's point number one, drop in impedance. Point number two, we tend to look at the unipolar morphology of the QRS, which is a QR-NAR pattern, and then we look at the ST segment part of the QR as well. If there's a QR, if the ST segment is positive, which means I'm still on the interventricular septum. But when this ST segment starts becoming negative, that's an important clue to tell us that we are past the left ventricular septum into the left ventricular cavity and do not proceed further. In fact, the conventional teaching is once you have perforated and gone into the left ventricular cavity and you have seen a negative ST segment elevation or ST segment depression on the unipolar current of injury, or if there is a significant drop in the impedance, it is better to remove the lead rather than to retract the lead and replace it in the interventricular septum. It's just important to come out of the interventricular septum completely and go to a completely new location. Because you have already created a burrow in the interventricular septum, and then if you tend to leave the lead, there's high chances of lead dislodgement happening later on in the course of the patient after you come out of the case. So if you have gone into the left ventricular septum, we would better retract the lead and go for a new location. So point number one, drop in impedance. On point number two, change in the ST segment current of injury from positive to negative. These are the points that tells me that we are probably much into the left ventricular cavity or past the interventricular septum. Did I answer that question, Deepak?
Yes and no, if I may say so.
Yeah, I would like to add something. Yeah.
Sorry. Yeah. I just want you to tell me. I mean, I agree with you. It's a challenge. You really don't know how. A couple of things. Mainly, when do you think it's enough? Do you actually want the left bundle pure capture or a non-selective capture? When do you say, I'm okay with, say, a left bundle area capture and not go in further to see if I'm going to get a better QRS? How do you control that temptation? Number one. And number two, when you have to pull back your lead, especially for stylet driven leads, how do you do it? Do you just yank it back or do you have a separate technique to do that?
Okay, so question number one. So when you have So I'll take the question number two. With stylet-driven lead, when it has gone past into the interventricular septum, into the left ventricular cavity, as I mentioned, we never try to place the lead back into the interventricular septum because we have already created a burrow, sort of a sulcus there, and then high chances that if you leave the lead into the same burrow, the lead might dislodge after the case or in the following days. So we never tend to leave the lead in the same burrow if we are past the interventricular septum, or if we have perforated the cavity into the cavity, we never leave the lead past there at that particular location. So question number one, how do we know that we are past? How much is enough? That's again a separate discussion, how much is enough? If I'm doing a case for a bradycardia indication, and I'm really not very stringent on the left bundle branch criteria, because the studies have shown us enough that the deep septal pacing is still good enough, uh, uh, end point where you get a Q and an R pattern. It's good enough end point. If you're doing it only for a bradycardia indication, I know the patient is not going to land up in a pacing-induced cardiomyopathy in the future. That's exactly our indication to prevent a pacing-induced cardiomyopathy in the bradycardia indication. But if you're looking at a heart failure indication, cardiac resynchronization therapy, and you're looking at correcting a left bundle branch block, there are no excuses there. We need to get into the left bundle branch. We need to capture the left posterior physical or the left bundle branch positively by all means. That is where it's very important to introduce another concept called the left bundle branch potentials. We start looking at the left bundle branch potentials and we make sure that we see the potentials, we capture the potentials, and then we might go for 2 to 3 lead repositionings in the same case until we get a satisfactory visualization of the left bundle branch potentials, which I will show you in the subsequent slides in other case examples. How do you look at those potentials and capture those potentials? And then make sure that you have captured the left bundle branch. So if you are looking at a bradycardia indication, you can be a little bit lenient on it. You don't really need to ensure a capture of the left bundle. As long as you are in that area, you get a QR pattern and the QR is less than 120 milliseconds. I would stop there. I would not push the lead any further in. But if you're looking at a cardiac resynchronization therapy indication, I would like to reposition the leads in multiple locations to make sure that we capture the left bundle branch block. In which case, I would try to take the lead a bit past into the left bundle, into deep in septum. There are occasions where we might perforate, but then I don't mind it. When we know that how much of depth penetration is causing the perforation, at least in the new location, we will have that insight in mind to stop the particular rotations at that particular possible depth, not to take it past it. So you may not get away in attempt number 1, but you might need to give 2 or 3 attempts to understand how much deep you need to get inside if you have a left bundle branch correction indication.
Nice. That was great. Dr. Crystal, do you want to add anything to that, or can we go on to the next one?
I think very, 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 very brief thing. It's again, if you deal with a non-responder to CRTP or CRTD, obviously you have to spend a little more time because it's the only modality at the moment to help this patient. But in all other cases, over manipulation of the lead can lead to its own complications related to the mechanics of hardware you use in particular. And in some, I hear that some operators are saying if they manipulate lead by about 15-20 minutes, they know they need to replace hardware altogether. So I will just stop right there. I think it's important to mention that we're in about minute of 52 or 53 of our podcast here. So without further ado, I do suggest we'll go one more case. Thank you.
Perfect. Go ahead.
Thank you. So there are interesting few more cases coming up there. This is a 54-year-old female with had a mitral valve replacement surgery in the past, long-standing atrial fibrillation, severe left ventricular dysfunction, all other comorbidities ruled out, no coronary artery disease, so possibly attributing the left ventricular dysfunction to the atrial fibrillation. And this is a permanent atrial fibrillation with failed cardioversions that we are looking at here, refractory tachycardia and heart failure, permanent atrial fibrillation. That's the ECG, that's the echo of the patient where you see the mitral valve, global hypokinesia of the left ventricle, dilated left ventricle, poorly contracting. So how do we go here? I would prefer to ablate the AV node, and that's exactly what was done in this case, AV node ablation. So such patients respond beautifully because to AV node ablation because directly you're removing 2 components of atrial fibrillation out. One is the irregularity, one is the fastness. Both the tachycardia and the irregularity is gone. And then in these patients of left ventricular dysfunction, earlier we used to recommend a biventricular pacing for these patients. Now, with the advent of the left bundle branch pacing, it is worthwhile. If you get a good left bundle branch area pacing capture, you could get away with a single chamber pacemaker. That was exactly what's done in this patient. A single chamber pacemaker lead was offered for this patient. More important, during the case, as I've shown here, in this sensing, apart from the QRS morphology, I would like to introduce this concept of looking at the signals preceding the QRS. These signals, sharp little signals, these are the vesicular signals, or the left bundle branch potential signals. If you're able to see these signals when you're deep into the septum, and that tells us that we are in the region of the left bundle, there is no need to get past this region. And if you capture there, you will end up getting the QRS that you desired, which is the right bundle branch block morphology and capture of the left bundle branch here. As shown here, this is unipolar cathodal capture, which is showing capture of the left bundle, hence the right bundle branch block morphology, very narrow QRS. As you can appreciate in V5, V6, the LVAT, the stim to the time to the peak in our wave is less than 70 milliseconds. QRS duration, this is at 100 millimeter per second speed, this particular trace. So the resultant QRS was very narrow, around 90 milliseconds. And this was concluding evidence that we did capture the left bundle. And when we moved from the unipolar to bipolar configuration, the anode also captured, as I showed you in the previous slide, resulting in an LB morphology, left bundle branch block morphology, because the anode is also capturing the right side of the septum. Nevertheless, the QRS is still very narrow, less than 120 milliseconds, and the LVAT is still short, as you can see here, less than 70 milliseconds. Yeah. And this is how the QRS looked. Background of atrial fibrillation, AV node ablated, and the patient had a QRS very narrow. The left ventricular ejection fraction obviously did remove remarkably after the procedure. So any comments on this particular case of AV node ablation and left bundle branch pacing, Dr. Eugene? How do you go around these patients of AV node chronic atrial fibrillation and biventricular pacing indication? Do you still prefer to have a biventricular pacing conventional pacemaker, or would you still prefer a single chamber pacemaker lead, as in this case?
Thanks. So again, it's a great presentation, and I do think that the fact that you will go with AV junction ablation makes you the only game, right? And so you have to try to achieve the best possible results. It's also a good case to comment on, his bundle pacing versus left bundle branch pacing, right? That allows you kind of additional levels of safety, right? In during AV junction ablation, his pacing may become unreliable. And B, his pacing may become unreliable over the time, right? You actually can lose capture in this area, as Deepak commented earlier. So I will stop here. Deepak, anything on your side?
No, I agree with you. I think given the challenges with pacing-induced cardiomyopathy, especially in a substrate that is already diseased, it will be incredibly important for you to get left bundle capture, at least in a non-selective manner, if not in a selective manner for these cases.
Yep. So the point that Dr. Eugene highlighted here is AV node ablation is basically ablating the AV node. And if you're trying to put a His lead exactly in that location, it becomes really difficult. Or if you have a His lead already in this location, and then still AV node ablation is possible, but it's cumbersome. And we might change the way the His bundle lead captures the His bundle. Thresholds could vary, a lot of other things could ensue. In which case, left bundle branch area pacing is a little more fruitful because there are no other complications that are expected because of AV node ablation in these patients.
Great.
So can I move to the case number 3?
Yeah, we'll make it on our third case, Deep, and then we'll take a summary. at the end of it all.
Yeah. So this is a 49-year-old female with heart failure symptoms, started with post-viral arthralgia, looked more like a post-infective sequelae. The patient had a typical left bundle branch block and a QRS of 160 milliseconds. Coronaries were normal, left ventricular ejection fraction was down. We did run a biomarker panel, which was all negative except for the high BNPs. So eventually we thought this was a case of uh, complete left bundle branch block and non-ischemic cardiomyopathy because of a post-infective sequelae. We ended up giving a patient the left bundle branch pacing link along with the coronary sinus lead, what we call the CS lead, showing you a few steps here. With the stylet-driven leads, this is a lead locking stylet that we use. So if you can make note of that white stylet at the tip of the lead, that is the lead locking stylet. That's a stylet-driven lead, which is basically Abbott's tendril lead. And then that screwing of the lead, with the lead locking stylet, the screw tends to come out of the lead and tends not to retract back into the lead. It holds the screw in position. So that's a demonstration of a lead locking stylet in case you're using a stylet-driven lead. And the other important step, counterclocking the sheath for septal contact. Once you're inside the interventricular, in the right ventricular cavity, it's very important to keep a counterclock on the sheath so that the sheath maintains a perpendicular orientation to the interventricular septum. Usually the counterclock orientation could be a 30-degree or basically the 3 o'clock to 4 o'clock location on the hub. If you're standing on the head end of the patient, a 3 o'clock or 4 o'clock location of the hub is basically where you will get a perpendicular orientation of the sheath to the interventricular septum and where you start screwing the lead past the septum. In the case of a stylet-driven lead, unlike the lumenless lead, we tend to be a bit slower because this is a heavier lead. You could easily perforate the interventricular septum, get past the interventricular septum, where the screwing is a bit slower, as you demonstrated in this case example. Of course, we do sheath angiograms to help us understand how deep that we are into the interventricular septum. As shown in both the examples here, the cathode is well past the interventricular septum or into the septum, but the anode is yet to penetrate the septum. So sheath angiogram really helps us to understand that the anode is still not past the septum, and hence gives us the confidence of trying to push the anode further into the septum, provided there's no drop in impedance while we take the lead past into the septum. In case we are not happy with the location, or if we have perforated in the left ventricular cavity, it is worthwhile hunting for a new location where you do counterclockwise rotations. This is important. You never try to pluck the lead out of the interventricular septum. You would either damage the helix, or more importantly, you would damage or cause a lot of damage to the myocardium there. What you would do is the reverse. You did clockwise rotations to get into the interventricular septum. Now you do give counterclockwise rotations to get past into the sheath, and invariably you will have some tissue that you would notice. And before you prepare to slit the sheath, you take the sheath past the right ventricular tricuspid valve back into the right atrium, leave a bit of a slack here. This is a demonstration of the hinge point. You see the hinge point on the lead here, very well showing both the anode and the cathode are passed into the interventricular septum. The hinge point of the lead is here, which tells us that the lead, both the anode and cathode, will pass into the interventricular septum. So once we have created a slack on the sheath, and then we start slitting the sheath, I would always say slit the sheath into 2 steps. In 2 steps, be it for a CRTK or something. The first step is slit the hub, which is basically this white portion. Once the white portion, the stiffer portion, take a pause, a brief half a second gap, and then start slitting the shaft. So that's about slitting the sheath there. And the particular patient that I had mentioned did have a we did end up putting a atrial lead into the backman bundles as well. So we got a really narrow QRS, as I had shown here, a bipolar capture, both the anode and the cathode capturing. Hence, you have a very narrow QRS and a LBB morphology here. The adjustment fraction did improve on the case. I will not go into case 4. That is a very interesting case as well. But then I would stop here to take up questions.
Dr. Chris,
Thanks
your
a lot.
thoughts?
Yeah, no, Deepak, I'm just deferring it now to you.
One of the major, really cool things that you showed, Deep, is the ability
Yeah.
to split. I mean, it is notoriously a big problem for people who are starting off to have the confidence to slit and to slit it well. I totally agree with you that the initial hub is it's almost like you have a high resistance zone and then you suddenly go into an area where there is low resistance. One small little thing that I would do, and probably you are also doing there, is you have to align the lead with with the slot that is present on the slitting tool. In the absence of doing that, there's a good chance that you'll pull the lead the moment you transition from the high resistance hub to the low resistance material of the sheath itself. So, other than that, I think this is an extraordinarily cool demonstration for slitting the sheath. And I, for one, am definitely going to remember the hub and the shaft whenever I teach it to my fellows next. Great, great. So, why don't we have you summarize then, Dr. Crystal, giving us some final thoughts, and then we can take it on for next time.
Great. Thank you. I showed one of the cases where we demonstrated left bundle branch potentials on the 12 lead screen. It's possible to see this left bundle branch potentials on the programmer as well, as shown here. This is one of the 4th cases where I will just show this one. That was another interesting case. So yeah, the summary. We started the topic presentation today highlighting what is RV pacing cardiomyopathy, the incidence of which is not less, which is still 10 to 15% in the interval follow-up of 1 to 5 years time. What are the indications? Henceforth, how did the left bundle branch pacing evolve? It started with his bundle pacing, and then we moved on to left bundle branch pacing. That's how the conduction system pacing. And now that we are also looking at the backman bundle pacing for the atrial pacing leads. Indications, there are 2 broad indications that we summarize. One is bradycardia indication, where the pacing percentage requirement is more than 40%. Remember, like patient, for example, a complete heart block, where 100% pacing would be needed for these patients. It is worthwhile pursuing left bundle branch pacing for these patients. However, in the course of the procedure, not really need to be very stringent on the criteria for left bundle branch placing. You should be happy if you get a QR pattern in V1 and a QR is less than 120 milliseconds. But then the indication number 2 is a heart failure indication for cardiac resynchronization therapy, where you are looking to correct the left bundle branch block. There are no excuses here. You try your best to narrow the left bundle, capture the left bundle. You start looking at left bundle branch potentials. You start looking at all the criteria. You make sure, even if you fail 1 or 2 times during the case, that attempt number 3 and attempt number 4, you get the left bundle branch capture. We showed a few case examples and a few demonstrations there on how you orient the sheath in RAO, and then in the endeavor views, how you take the lead past the interventricular septum. Fast rotations recommended for the 3830 Medtronic lead, slower rotations for the stylet-driven leads. And then how you look at 2 important things. One is the QRS morphology while you screw the lead, and point number 2 is the increase and drop in impedance, and then how you look at the ST segment on the unipolar QRS to suggest whether you're into the interventricular septum or you're past the interventricular septum. So that's my summary of today's topic.
Thank
Thanks,
you.
Deep. That's absolutely a great presentation. I would only mention a few minor things. At the end of the day, there's no strong data, putting one hardware in front of another hardware. I think a lot of a choice should still depend on implanter preferences. and individual skills. That's probably the most important part to remember. You do nothing wrong if you use the tools which you think you use the best. That's important. And Deepak, I'll give it to you to final comments and conclusion. Thank you.
Thank you. Thank you, everyone. Thank you, Dr. Deep Chand, Dr. Crystal, for participation into the World Series of Arrhythmia sessions on pacing, sponsored by Medtronic and kindly taken care of by Magnum Opus for their technical support. I thank Dr. Otto for the opportunity to be able to moderate these sessions. This is an important evolving way or technique for pacing. And I hope all of you who tuned in today and those of you who will see it offline at a later point on the WSA website would send in questions if you didn't understand anything and would share it to your friends too. Thank you once again for your participation, and I hope all of you have a great weekend. Thank you, Dr. Crystal. Thank you, Dr. Deep. I hope to see you guys in person sometime.
We should, yeah.
Thank you. Thank you for the opportunity.
Thank you, guys.